Welcome to the Antepartum lecture. Before we get started, please make sure that you do have the PowerPoint presentation that was emailed to all the students, and also it can be found on Canvas under OB Didactic, and that is the Antepartum lecture PowerPoint presentation that will go along with this lecture recording. One of the things we're first going to talk about is goals and objectives. So at the end of this content, all the students will be able to apply the concepts of normal physiologic and psychological changes in pregnancy to develop a plan of care for this pregnant patient. Objectives, yes, we have objectives. Students will be able to understand the difference between normal psychological and normal physiologic changes in pregnancy. You'll also be able to discuss the management of normal pregnancy and also outline a plan of care for a normal patient. As we were talking about in objectives before we move on to nutrition, students will be able to outline the plan of care for a normal pregnant patient by each trimester. Nutrition. So we need to have a pregnant patient as healthy as can be. So although adequate nutrition during pregnancy cannot guarantee a good pregnancy outcome, it does make a difference. It will make an important contribution because both the nutritional state a woman brings into pregnancy and her nutrition during pregnancy does have a direct bearing on her health and on fetal growth and development. With that being said, a poor diet, such as one deficient in folic acid before and during pregnancy, for example, is associated with fetal growth restriction. Or birth anomalies, such as neural tube defects that we will talk about in the lectures that are to come. So inadequate maternal dietary intake could result in fetal deprivation with premature birth, birth of a stillborn, or congenital birth anomalies. Pregnant women do need an additional 300 calories a day. So we will go through the daily nutrition requirements for a pregnant woman. First one here we have is protein, 3 servings a day. That includes meats, eggs, and legumes. Carbs and grains are 6 servings a day. Dairy is very important. Dairy is very important for fetal skeletal tooth formation. An example of dairy is a quart of milk a day. Helps alleviate occurrence of leg cramps. Vegetables, 3 servings a day. That's green, deep yellow vegetables, which is also good because it is loaded with vitamin C. Fruits, 2 servings a day. Fruit is really good for folic acid and red blood cell formation. Weight gain during pregnancy. Normal appropriate weight gain averages about 25 to 35 pounds for women with a normal pre-pregnancy weight. As I'm going through this lecture, I'm going to give you page numbers. In those page numbers, there are some boxes, and that is a great study resource for you. And also page numbers where you can find this information in your book. So with the nutrition and the weight gain, just write a little reference on page 286, box 13.2. To continue on with the weight gain on the slide, 10 to 13 pounds patients will gain in the first 20 weeks, and a pound a week after 20 weeks. And just a little rundown of what this weight gain is and how the patient now that's pregnant will gain this weight is fetus, placenta, and amniotic fluid all accounts for about 11 pounds. The uterus is about 2 pounds. The increase in blood volume is about 4 pounds. Breast tissue is about 3 pounds. And all the extras that we call extra weight, we call it, we say that it's maternal stores. Next one on your slide is eating disorders. We will go to eating disorders, which is pica. Pica is an abnormal craving for non-food substance. An example of pica is clay, eating dirt, eating cornstarch. Your most common one that you will see very often if you're around a lot of pregnant patients is ice cubes. But all of this, because it's an abnormal craving for non-food substance, usually accompanies iron deficiency anemia. Okay, so it's very important if your patients tell you that they have cravings for any of these, pay attention because they might be suffering from an iron deficiency anemia. And we have over-the-counter medications. The only over-the-counter medication that we should allow any pregnant women to take is prenatal vitamins. Because we need to be careful, these drugs cross the placenta, and women should not take any drugs or specifically prescribed. They need to be specifically prescribed or approved by the healthcare provider. So then again, you'll hear me saying this a lot throughout all the lectures that prenatal care is very important. Because if you have a healthcare provider, a clinic, that you are getting prenatal care, they're just a phone call away. You have a symptom, you feel something's not right. We all know our body, so we know when something's not right. They can pick up the phone, they can call and have something maybe over the counter that's approved by the healthcare provider or specifically prescribed. Smoking is still a no-no. No smoking. Smoking is a vasoconstriction. It'll vasoconstrict the uterine muscle and then will limit the blood supply to the fetus. So patients still smoke, but smoking is really a no-no, is a vasoconstrictor. Smoking also causes intrauterine growth restriction, and it causes a decrease in birth weight. Smoking also causes teratogenic effects. Okay, what is a teratogen? Teratogen is any factor, whether it's chemical or physical, that affects the fertilized ovum, embryo, or fetus. And I'll give you a little pathophysiology of how all that works. First, it's an ovum, then there's ovulation, then it's a fertilization. We have the embryo, and the embryo implants about 5 to 8 weeks. Okay, got the zygote, got the fertilization, and the implantation of the fetus at about 5 to 8 weeks. So yes, a teratogen is any factor, chemical or physical, that affects the fertilized ovum, embryo, or fetus. Going back to smoking, we gave you the causes of why smoking is so important because it's a vasoconstriction. So no smoking, and also under the category of no smoking, please write no caffeine. Caffeine stimulates the central nervous system and decreases birth weight. Also under smoking, I want you to put on there no alcohol. Alcohol increases congenital deformities, and it's a cognitive impairment. We will talk in the lectures to come about the moms that drink alcohol during pregnancy, and it has a direct effect to congenital deformities. So we will talk about those in the lectures to come. So those three are a no-no. No smoking, no caffeine, and no alcohol. And if they do, then little by little, they should start to eliminate and stop smoking, stop drinking caffeine, and don't drink any alcohol. Okay. Folic acid. Folic acid is good for the formation of red blood cells. Before pregnancy, they take a multivitamin that has 400 micrograms of folic acid in it every day. This is what the American Academy of Pediatrics recommends, is that pregnant women do take a multivitamin that has 400 micrograms of folic acid in it every day before they get pregnant, at least 3 months before, to prevent neurotube defects, okay, or spina bifida. That is the failure of the spinal cord to fuse together. Because remember what folic acid does. It's a formation of red blood cells rich with oxygen. So during pregnancy, prenatal vitamins has about 600 micrograms. So they don't need to take that extra folic acid anymore, because during pregnancy, their prenatal vitamins will have that 600 micrograms. And women do need an additional iron supplementation during pregnancy as well. So iron is also on that prenatal vitamin. We can talk about pregnancy. We don't talk about pregnancy hormones. So estrogen is our first hormone, and you'll hear me say a lot, thank you, estrogen. Stimulates uterine development to provide an environment for the fetal growth. It also prepares a breast for lactation. That's all about estrogen. Another famous hormone is HCG, human chorionic gonadotropin. It stimulates progesterone and estrogen production to maintain the pregnancy. This is the hormone that comes live and will signal the body that you are pregnant. Once implantation occurs, this HCG, this pregnancy hormone, will increase. And then it will signal the body that you're pregnant. When women first miss their period and they're say, I'm late, you can go to the drugstore. You can pick up a pregnancy test. And what it's showing, it's positive. Even after just being a day late, it is showing, what is showing on that pregnancy test is this urine HCG. It's already being detected, and that's what it's showing, is the urine HCG. We also can do a blood test, and the blood test is a quantitative beta HCG. So the blood test that we can do for the HCG is quantitative. It gives you numbers. And it closely is monitoring the development of a pregnancy, and that's what the quantitative is. The levels continue to increase. Every woman's level for HCG is differently. For example, at 5 weeks pregnant, when women go, usually as early as 5 to 6 weeks, to the OB, to the healthcare provider, so that they can start getting their prenatal visit and all of their labs done, so we can have a baseline. At 5 weeks, HCG, that would be a beta, because they draw your blood, right? And you get quantitative, so you get numbers. 5 weeks, 18, the levels can be 18 to 7,340, and it's MIUs per milliliter, okay? Milli international units per milliliter. So that's how different, one patient is from the other. And it will usually peak, HCG will usually peak at about 8 to 12 weeks. And at 12 weeks, those levels can go as high as 288,000. This is good because we can get a phone call and we could say, mom can call. Okay, the pregnant patient will call and say, I woke up and I'm bleeding and I really don't know what's going on. And the first thing that we're going to do is we're going to say, come to the office or go to triage, or come to the office and let's draw a beta HCG, and then they go for an ultrasound. And what we want to compare is their original HCG when they first came in, let's say, 6 or 7 weeks, they were 6 or 7 weeks pregnant, to maybe now that she is 12 or 13 weeks pregnant and she's bleeding. And when we redraw the HCG, we want to see is higher levels, right? Because it peaks at 8 to 12 weeks. So we want to see that if they were a 20 or if they were a 3,000 before, it's really going to be really high now that she is, let's say, 12 weeks pregnant when she calls her healthcare provider's office because she's bleeding. Okay, so HCG levels are really good, and we monitor them closely as the pregnancy develops. The next wonderful, famous hormone, it's HPL, and this hormone of pregnancy promotes lipolysis. Okay, it stimulates the growth of the breast. Okay, so it is also HPL. It's produced by the placenta. It breaks down fats from the mother to provide fuel for this growing fetus. HPL is also an insulin antagonist, so it inhibits the release of insulin. Another little thing I can say about HPL, human placental lactogen, is that it decreases the maternal metabolism of glucose to allow for more fetal growth. The next famous pregnancy hormone is progesterone. Progesterone is associated with maintaining the endometrium and inhibiting contractions. It prevents abortion or miscarriage. You will see that name used, together, abortions, miscarriages, and aids in the preparation for lactation as well with progesterone. So progesterone does maintain the endometrium and does inhibit uterine contractions. So this is why sometimes when moms are trying to get pregnant and they continue to have miscarriages, what we do is we can do in the healthcare provider's office, we will do a hormone panel. And if progesterone is low, this is when we can give that patient progesterone because we are making this endometrium stronger. And if mom has the adequate levels of progesterone that she needs, then of course her uterus will not start to contract and she won't lose her pregnancy. So progesterone is very important in pregnancy and it needs to be at high levels, okay, for the patient to be able to maintain this pregnancy. And we have good old prostaglandin associated with the onset of labor. This is lipids, and lipids are found throughout the female reproductive system. There's increased concentrations that are found in pregnancy. And also, when prostaglandin levels are decreased, it contributes to pregnancy-induced hypertension. The exact cause still of pregnancy-induced hypertension, why hypertension happens during pregnancy, the exact cause is unknown, but one of the many causes is that if patient has low levels of prostaglandins, then it might contribute to pregnancy-induced hypertension, getting hypertension during pregnancy. And then relaxin. You'll hear about relaxin again when we talk about the Antepartum, which is a labor and delivery lecture. Relaxin inhibits uterine contractions and it softens the cervix. Okay. It's found in maternal serum from the time of the first missed period, and it's made by the corpus luteum. So you will hear a lot about hormones as we're going into the following lectures to come. And you will hear me say a lot, thank you to estrogen and thank you to progesterone for a lot of things, because yes, these levels are very important to keep a pregnancy, maintain a pregnancy. Adaptations to pregnancy. Here we're going to talk about the normal physiologic changes. These are changes that occur during pregnancy and are the basis for the signs and symptoms used to confirm a pregnancy. And then, of course, we have psychological changes as well. We will go through all of them. We're going to go head to toe and start with physiologic changes. Cardiovascular system. There is a state of hemodilution, which we call a normal physiologic anemia. Okay? And that's when the plasma volume increases about 50%, 7% decrease in hematocrit. And that's because the plasma levels increase and it exceeds the increase in the red blood cell production. Normal. There is also something called vena cava syndrome. And this is a supine hypotensive syndrome. Okay? This is why pregnant women, you don't want them to lay supine, lay flat on their backs. It is because the uterus will compress the vena cava, and I want to show you a picture. The uterus compresses the vena cava, which decreases the blood flow to the right atrium, which decreases blood pressure. Okay, so this is what's happening, the vena cava syndrome. The uterus compresses the vena cava, which decreases blood flow to the right atrium, which decreases blood pressure. Okay, so symptoms, yes, mom will start to feel very pale. She'll start to say that she's dizzy, clammy skin. She'll start to get hypotensive, fetal distress. Okay. How do we prevent this? How do we treat this? Lay her on her left side immediately and put a pillow under her right hip so that left side, heart is on the left side, perfusion. Okay, perfusion for that baby. And this is how we're going to fix this vena cava syndrome. This is why head of bed has to be elevated for pregnant women. They have to be on their left side. Okay, if you're going to sit them in bed, make sure their head is elevated, never flat on their backs, because they will be prone to vena cava syndrome for sure. Hypercoagulation or other normal physiologic cardiovascular change. Blood volume increases about 45%, and red blood cells increase about 18 to 30%. Then another physiologic change is heart rate increases. So cardiac output is increased about 30 to 50%. There is an increase in heart rate of about 10 to 15 beats per minute of an increase. So if mom normally runs about 70, she'll be running about 85 beats per minute more. So it does increase. So it's normal to see in the labor room, you know, normal adults run about 60 to 90 of a heart rate. So it's normal that sometimes we see heart rates of, 90 and 100, because if they run higher, for example, if they normally run in the 80s, then 15 beats per minute higher, we will see them in the 95s. There are blood pressure changes as well. There is something called postural hypotension, decrease in blood pressure, postural hypotension, and that may result as the uterus presses on the pelvic and femoral vessels, and that will limit the blood return to the heart. Okay, So that is what we call postural hypotension. Okay, uterus presses on the pelvic and femoral vessels, and it limits the return to the heart. Then we have the respiratory system. Okay, the upper respiratory, remember this is normal physiologic changes. So the upper respiratory tract becomes more vascular in response to increased levels of estrogen. Okay, the capillaries become engorged, edema develops within the nose, the pharynx, the larynx, the trachea, the bronchi. There is marked inflammatory response that can develop into a mild upper respiratory infection. So we have to be very careful and listen to our patients. They do develop this nasopharyngeal edema. Okay, because again, thank you to estrogen, the upper respiratory tract becomes more vascular in response to increased levels of estrogen. And it does cause this nasal pharyngeal edema, which is a nasal stuffiness. A lot of moms, they start with this pregnancy and immediately they're like, they can't breathe, and they start to get this nasal stuffiness. And that is because due to increased levels of estrogen. So thank you, estrogen. And then shortness of breath, which yes, they start to hyperventilate. Everything is pushed up. We will see some pictures that I have for you as we continue on with the lecture. Then also normal physiologic change is the renal system. Okay. Remember that kidneys are responsible for regulating electrolyte, acid-base balance, excreting waste products, and conserving essential nutrients. Okay. So the renal system does have some normal physiologic changes as well. There's glycosuria. Okay. Simple as kidneys are not able to reabsorb all of the glucose that's being filtered, so it results in glycosuria. It might be normal, or if there's too much of it, it might indicate gestational diabetes. And we will talk about gestational diabetes. Then there's glomerular filtration rate, the GFR, and that increases about 50% during the second trimester, and it will usually remain increased until delivery. Then we've got some urinary frequency changes, okay, and you have it there on your slide. First trimester, the uterus presses on the bladder, and of course, there's a lot of urinary frequency. Second trimester, as everything starts to move up, it's relieved by the uterus moving into the abdominal area. So, of course, mama doesn't have to be in the bathroom all of the time. By the third trimester, yes, this pregnant patient usually has to go use the restroom very frequently because urinary frequency as a presenting part presses on the bladder. And again, I want to mention as we talk about the renal system, how the side laying position, left side or right side, we used to say all the time in OB forever and a day that the left side would be good. But we noticed through the years that, and with a lot of research, that babies like the left side or like the right side. Priority-wise, I would put mom on her left side first because it increases renal perfusion, it increases urinary output, and it decreases edema. So side laying position is wonderful. We go on our left or we go on our right. Okay, it will increase renal perfusion, increase urine output, and decrease edema. You will hear us say that a lot with pregnant patients. Go on their left side for perfusion. The baby doesn't like it, go on the right side. Gastrointestinal system, the GI system. Okay, the GI system, as the baby gets bigger and everything is pushed up, it does worsen as the gravid uterus presses on the intestines. And there is something called hyperpitualism. That is increased saliva formation, and that is caused again by an increase in estrogen levels. Then we have pyrosis, which means heartburn. Okay, we also have part of the normal GI system is we have constipation, we have gas, we have flatulence. And this is all happening due to the displacement of the stomach and the slowed intestinal peristalsis. Then we have a decrease in gastric motility and also nausea and vomiting. And this is nausea and vomiting is very common during the first trimester. Okay, as some patients with HCG, human chorionic gonadotropin hormone, if HCG is very high, remember we talked about some patients have lower levels, some patients have higher levels of HCG. Those patients that have high levels of HCG during their first trimester, okay, those first full 12 weeks, will usually have that morning sickness, that nausea and vomiting. And also could be caused by those patients that have very high progesterone levels as well. Moving on to skin integumentary system, we've got two pictures there as well. So increase in pigmentation, that's again, thank you to estrogen, where the increased levels of estrogen are usually seen, that increases pigmentation. And it's usually seen in the areola, the nipples, and the vulva area. Also, you have stretch marks, which is strium gravidarum. Those are stretch marks. And those results from the stretching of the connective tissue that's caused by an increase in the adrenal and the steroid levels. And then you have the patient to the right over here to the right, which has a black line, linea nigra, a black line that's extending, okay, keeping the pace with the rising height of the fundus from the symphysis pubis down here, and keeps a pace up to the growing fetus. Okay, the top, okay, is the fundus, and down here is the symphysis pubis. Okay, so it's keeping the pace with the rising height of the fundus. So it's a darkly pigmented line that extends from the symphysis pubis to the top of the fundus. Okay, so if this patient right here is about 36 weeks, then look at her incredible, thank you, hormones. Thank you to adrenal and steroid levels. This dark line continues to increase. Now, once mom delivers and the hormone levels all start to go down and stabilize, then this black line will disappear. Okay. Chloasma, again, with the increase in pigmentation, chloasma is what we call the mask of pregnancy. And as you could see in this picture, okay, she's got the darkening of the skin, okay. It could be around the eyes. It could be darkening skin around the forehead. You could see that she has it here a little bit lower than the eyes and her cheeks as well. Okay, this one tends to disappear if mom stays with her birth control pills, let's say with the choice of contraception and takes birth control pills. Then of course, because we've got estrogen again in the birth control pills, then we might see that it doesn't all go away. But normally the mask of pregnancy does tend to go away or get lighter. Musculoskeletal system. So lordosis is what happens. And this is due to pregnant posture. This poor patient up here on the top. Due to pregnant posture and gait, which causes backache. And it causes mom to have lordosis. It's the curvature of the spine that increases due to the weight of the gravid uterus. Okay, because now the uterus has a fetus inside. And then we've got carpal tunnel syndrome, and that increases with fluid volume and edema. A lot of research, really, we can't pinpoint why pregnant women all of a sudden have their wrists that really hurt and they need to wear braces, which is what will help them. And then when they no longer are pregnant and they've delivered their baby, their risks come back to normal again. And all the research has found through the many years is increase in fluid volume and edema. And then you wonder what happens to the stomach when that stomach pops out. Well, you do have muscles, okay? And these muscles separate, and that is diastasis recti. That's the separation of the rectus. Skip the slice. We're back here to diastasis recti. That is a separation of the rectus abdominis muscle that results as the gravid uterus enlarges. Okay, so this is what happens. It's very tight, and then it separates, and then this baby, okay, as baby grows in utero, makes room and expands those muscles. Then we go into the endocrine system. Okay, there are normal physiologic changes. There are profound endocrine changes that are essential for pregnancy maintenance, normal fetal growth, and postpartum recovery. Okay, and one of them is the thyroid gland. The enlargement does cause an increase in metabolic rate. Within a few weeks after birth, the function of the thyroid gland returns to normal limits. Then we have the parathyroid. Parathyroid enlargement allows for better use of calcium and vitamin D. Parathyroid usually has normal levels after birth. And just on a little side note with the parathyroid gland, that the peak levels occur between 15 and 35 weeks. And that's amazing because that's when, between the 15 and 35 weeks is when we need growth of the fetal skeletal are the greatest, is between 15 and 35 weeks. And that's when it peaks. And that is when, again, with the purpose of the parathyroid gland and the changes, it allows for better use of calcium and vitamin D. And this is when it's peaking, when we need it for growth of that skeletal, of that fetal skeletal little system. So the pancreas also plays a part in the normal physiologic changes, and that's fetal requires an increase in glucose for its growth and development. Okay. And then we have the pituitary gland, and that again has an increase in secretion of prolactin and prepares the breast for lactation. A picture, a visual of what is going on, all the different things that we are talking about, since we are going to talk about the reproductive system. We've got the uterus, mucus plug. We're going to talk about the cervix, the symphysis pubis that we keep talking about, which is right over here. Okay. It lies between the pelvic bone and allows a baby to pass through. The vaginal canal, the perineum, the amniotic sac, the placenta, and the umbilical cord. We're talking about normal physiologic changes with the reproductive system. The uterus does increase in size. It's palpable by the end of the 12th week gestation, and it is above the symphysis pubis. So changes of the uterus, we've got lightening. Lightening is a descension of the fetal head into the pelvis. We've got the Hagar sign. And this was, it got the sign of Hagar because Ernest Alfred Hagar was a German gynecologist, and he was famous for developing a new medical tool and techniques. And this was born in 1830 and he died in 1914. So it's been Hagar's sign for a long, long time. And this is usually evident at about 6 to 8 weeks. So when we put mom on stirrups and we do a sterile vaginal exam, we notice that softening of the lower uterine segment. And then you hear sometimes false labor. It's Braxton Hicks contractions, I always call them. It's a rehearsal, okay, what's to come with the true contractions, okay, true labor. Then we have changes, and that's an example of Hagar sign, okay, the softening of the lower uterine segment, okay. This is during a sterile vaginal exam when mom goes in for her first prenatals. And then since we are talking about the reproductive system, we've got the vaginal canal, we've got the cervix, and then of course we've got the uterus, we're the home for that fetus. And we've got more on the reproductive system. So the cervix. Evident, the Goodell sign is a softening of the cervix, and that is evident at about 8 weeks of pregnancy. Okay, so if you get your finger and you touch your desk and your desk is really hard, that is exactly what the cervix is. It's a very hard organ. But amazingly so, with all of the hormones, the normal physiologic change is that with pregnancy, the cervix starts to soften. And that is part of Goodell's sign. And that is why as we reach pregnancy, about 40 weeks, okay, more than 37, so 38, 39, 40 weeks, that cervix can soften to the point of dilating to 10 centimeters. Only happens during pregnancy. And then we have the mucus plug. The mucus plug does act as a barrier under the influence of, thank you again, estrogen. The cervix secretes mucus that forms a plug at the opening of the endocervical canal, and that's what we call this opening right here is the endocervical canal, and it limits bacteria from entering the uterus. So you've got your vaginal canal, and you've got your cervix, and then you've got your uterus. And of course, a mucus plug right on the opening of the endocervical canal will prevent all infections and anything that will go up to the uterus to touch that baby. So it will limit the bacteria from entering the uterus. And some vaginal changes. We also have, again, thanks to the increase in estrogen hormone, we have Chadwick sign, which is evident also at about 6 to 8 weeks. And it is a bluish purplish discoloration of the vaginal wall and the cervix during pregnancy. There's also an increase in vaginal discharge, becomes more acidic, more white and thick. And then, of course, thanks to estrogen and progesterone production, there are changes in the breast as well. There's fullness, tingling, tenderness, darkened areola. We talked about the darker pigmentation. They get full. They look full, so they get prominent blue veins. And it could secrete colostrum by the 16th week. Then we're going to talk about psychological changes, right? We talked about physiological changes, the body, and now we're going to talk about physiological changes. The mind is a wonderful thing. So all the thoughts, physiological changes. And all these changes physiologically that happen in the first trimester are all about accepting the pregnancy. Now mom finds out that she is pregnant. Now this patient finds out that she is pregnant. And she has to accept the pregnancy. So there's 3 things that we think about when we talk about psychological changes in the first trimester. Acceptance. So accepting the pregnancy. Was it intended? Was it unintended? Unintended. Is it going to affect my career, the timing? And then announcement. Am I going to announce the pregnancy or not? And then sometimes a feeling of ambivalence. It's a feeling that you're pleased or you're not pleased about the pregnancy. Okay. Then we have second trimester psychological changes. We go through differentiation, and then the second trimester is all about accepting the baby. Okay, now the pregnancy becomes real. Okay, there's fetal embodiment, and there's also visualization. So it does become real. This pregnancy does become real. In visualization, you can even feel, you could see the baby on an ultrasound, and you can also feel fetal movement. And feeling fetal movement by mom, mom is the one that tells you, okay, by the mom that she feels fetal movement. This is called quickening. And this occurs in about between 16 and 20 weeks. So this feeling of fetal movement by mom, this is called quickening. And this occurs between 16 and 20 weeks gestation. And then we have the third trimester, normal psychological changes. And here are we preparing for parenthood. Okay. This mom now is very self-absorbed with pregnancy. And all these changes occur with the separation of the baby. I have been pregnant now for 30x amount of weeks. I've been pregnant now for all this time. And I'm not going to be pregnant anymore. I'm not going to be carrying my baby with me anymore. She's concerned with a safe delivery. She maybe, childbirth classes, childbirth education. Am I going to do it? Am I not going to do it? Highly, highly recommend, because you have this fear, especially first-time moms. It's the fear of the unknown. You don't know. But the better prepared you are, and it will decrease that anxiety at the time of having to go to the hospital and deliver this baby. And then nesting, that, buying clothes, changing names, doing the baby's room, and you're doing all this nesting. Then we have to leave something for the partner, okay? When mom has that close connection with her partner, okay, close connection with that father of the baby, that close connection, then of course they say that the partner also gains weight, has cravings, has nausea, and that all of that is Covade's syndrome. So we have to leave something. We always have to leave something. Normally when I'm in class, I always say that we have to leave something for the boys, because in all of the lecture we talk about mom, the pregnant patient, and we never talk about them. So we have to leave something for, obviously, that partner. And that is, of course, when, mom and dad have a close, to each other, okay? Whether it's the husband, whether it's the partner, whether it's the significant other, okay? But they're close to mom, so that's when they have that tight connection, and that's called Covade's syndrome. Then, of course, we have signs of pregnancy, okay? And what tells us that mom is pregnant? Okay, well, mom will come to the healthcare provider's office, and some presumptive signs of pregnancy. These are subjective, and these are findings reported by the mom that suggest the presence of a pregnancy. Okay, and the picture to the right is really funny, because obviously she looks pregnant, but then he says, well, I think we should run a pregnancy test just to make sure, because subjective is everything that she's telling him. Okay, findings reported by the mother that suggest the presence of a pregnancy. And what are those? That could be amenorrhea, okay, missing one or more periods, nausea and vomiting that mom is telling, so it's subjective, okay, she's reporting, fatigue, breast changes, okay, or even quickening, even saying, I feel the baby move. Let's say she's a late prenate start and she's already more than 16 weeks pregnant, and she's coming to see the healthcare provider for the first time. Then she's reporting that she's feeling, this baby move already. Well, that is called quickening, and that is between 16 and 20 weeks. Okay, so this is all presumptive. This is all subjective. This is all findings by the mom that suggest the presence of a pregnancy. Then we have probable signs of pregnancy. This is objective. These are findings that are noted by the healthcare provider that's going to suggest to the healthcare provider, okay, a pregnancy is present. Okay, and this is what we just talked about a little bit ago. These are pelvic organ changes. Goodell's sign, because remember Goodell's was a softening of the cervix. Okay. Hagar sign, it's a softening of the lower uterine segment. Then we have Chadwick sign, bluish purplish color of the mucous membranes, the vaginal wall. These are all objective. These are all findings that are noted by the healthcare provider that do suggest the pregnancy is present. We have an enlarged abdomen. That's all probable. That's all objective because we could see it. Changes in pigmentation. Healthcare provider could see it. That's all objective. Okay. We can do a pregnancy test that's positive. Let's say we do a urine pregnancy test in the office and it's positive, and that's objective. I can see that it's positive. But the difference between that and being positive is that a positive pregnancy test, which tells me that there's HCG, high levels of HCG in the body, enough to say, okay, it's detected a pregnancy and it's now showing on the pregnancy test, could also be caused by a molar pregnancy. Okay, and molar pregnancies don't have a heartbeat. So with that being said, a positive pregnancy test will stay under probable because there's only three things that will confirm, three findings that will confirm a positive sign of pregnancy. Okay, so positive pregnancy test is still probable. It's objective. I could see it, but because it could be caused by a molar pregnancy, which we know that doesn't have a heartbeat, so it's not a true pregnancy. We leave pregnancy test as being probable. And we will talk about molar pregnancies when we talk about high risk pregnancies. We'll talk about molar. Okay. So positive diagnostic, positive is truly diagnostic. That is the point of no return, and these findings do confirm a pregnancy. And that is a fetal heart tone. Okay, fetal heart tone, usually about 110 to 160 beats per minute is normal fetal heart tones. Okay, and we can hear it on a Doppler as early as 10 to 12 weeks. We're going to talk soon here about a diagnostic test, and we could do a vaginal ultrasound as early as 5 to 6 weeks. But by Doppler, we can hear the heartbeat by 10 to 12 weeks. Okay, so findings that confirm a pregnancy are going to be fetal heart tones. If you hear a lub-dub, and a heart sound, you know that's the point of no return. That is a fetal heart tones. 110 to 160 is the norm. Then fetal movement that's felt by the examiner. Okay, and we can start feeling fetal movement by 20 to 24 weeks. So that would be another finding that would confirm pregnancy. So fetal heart tones, fetal movement that's felt by the examiner about 20 to 24 weeks. And the third finding is visualization of the fetus by ultrasound. Okay, so we can do as early as 5 to 6 weeks, we can do a vaginal ultrasound. And even the brain and the heartbeat, it could be visualized by 8 weeks, as early as 8 weeks. We can have the brain and the heartbeat visualized. So visualization of the fetus by ultrasound, that would be your third finding, and that would be your positive diagnostic sign of pregnancy. Then we have some warning signs of pregnancy. Vaginal bleeding. Vaginal bleeding, bright red blood is never good in pregnancy. And that will give you a challenge of a third trimester challenge. That's when abruptio placenta or a placenta previa, we would think about, it would red flag in our brains to think about why is mom having vaginal bleeding? okay? Uterine tenderness, contractions, abdominal pain, borderline, a board-like abdomen, okay? Very, very stiff. So that's never good, okay? Abruptio placenta is a premature separation of the normally implanting placenta. So again, we're going to have fetal distress with that. We're going to have pain with abruptio placenta. I wanted to mention it here. I can't go without mentioning it to you and also giving you a brief explanation because we will talk about abruptio and placenta previa when we talk about our high risk. So our abruptio placenta is premature separation of the normally implanted placenta, and that's very painful. And then we can also have placenta previa, which is placenta that's implanted in the lower uterine segment. Okay, normally when the placenta implanted on the top of the fundus of the uterus, on the top of the uterus, but when it implants in the lower uterine segment, then of course there's a big chance of vaginal bleeding. Maybe we'll have a whole lot more explanation on this as we go along in our lectures. But it is part of the warning signs of pregnancy, and I can't go without explaining it to you. If I'm just going to tell you vaginal bleeding, I'd like to give you the rationales for why we say what we say. Plus, I love to talk. Second one on here is decreased fetal movement, and that's obviously fetal death. That is a big warning sign of pregnancy. Now, headache, edema of the hands, face, edema of the fingers, visual changes, that is all related to that pregnancy-induced hypertension, that hypertension that might start to happen during pregnancy, okay? And that is a warning sign of pregnancy. Also pain and then symptoms of infection. And what are those? That's temperature of more than 100.4, 100.4. Burning on urination, we think it might be a urinary tract infection. Abdominal or chest pain, sometimes that happens with premature labor or an abruptio placenta, okay? That premature, remember abruptio placenta, that premature separation of the normally implanted placenta. Chills, fever, we think it's an infection. Another symptom of infections could be that persistent vomiting. Remember I told you in the first trimester, those first 12 weeks, very high levels of HCG can cause nausea and vomiting. But if it's nonstop, if it's constant, and mama can't drink anything, she can't eat anything because she's persistent in vomiting, then that becomes a diagnosis. That is hyperemesis gravidarum, something we need to be careful because we have a little growing baby inside, and then now the baby, everything mama takes for nutrition is coming right back out. We will also talk about that in high-risk pregnancy, but of course I need to mention it because symptoms of infection, if any of this happens, those are warning signs of pregnancy and usually happens very early on. So we will talk about hyperemesis gravidarum, make a little note on it, and we will talk about it. And then an increase in fluid from vagina, and that is rupture of membranes. That's another warning sign of pregnancy. We will have plenty of pictures to follow in the other pregnancies to show that the baby, and as you read, okay, this baby is inside the uterus, but this baby is surrounded by amniotic fluid. So it's a nice sealed, okay, amniotic fluid sac the baby is in. And that sac should not rupture. This is what the water breaking, everybody says, oh, the water broke. That's important. That is the amniotic sac, okay? And that sac should not rupture until mom reaches full term. Okay, anytime after 37 weeks completed. So 38, 39, 40, that is all full term. So if there's an increase in fluid from the vagina, then that's rupture of membranes. And if she's not full term to be ready for this baby to get delivered, then that is a definitely warning sign of pregnancy. That's a little list for you. Now we are going to talk about prenatal screening. That's very important. And I just want to make sure we're not frozen. I want to make sure that we are continuing. Okay, there we go. I want to make sure we're not frozen on prenatal screening here. First thing I want to talk about is gestational age and Nagel's rule. This is how we find out when patient will deliver. Okay, expected date of delivery, EDC, EDD, expected date of confinement, EDC. And this is done with Nagel's rule. Okay, we're looking for gestational age. We're looking for when mom is going to deliver. So we go back from the first day, okay, of her last menstrual period, the first day of the last menstrual period, we're going to go back 3 months and we're going to add 7 days. Okay, from the first day of her last menstrual period. So if we say that the first day of her last menstrual period was November 7th, we're going to go back 3 months, not counting November. So we're going to go back October, September, and August. And that will be August. We're going to add 7 days. So that's August 7th plus 7 is August 14th. Don't forget to change the year because November was last year. For example, for this example, November was last year in 2019, and then August now. So this mama delivered August 14th, 2020. Okay, so this would have been her expected date of delivery, would be August 14th, 2020. Okay, so Nagel's rule is mom's first day of her last menstrual period. You're going to, not counting that month, you're going to go back 3 months and you're going to add 7 days. So the example I gave was November 7th was the first day of her last menstrual period. So if you do Nagel's rule and you go back 3 months, that is October, September, that is August 7th. If you add 7 days, that's August 14th. And don't forget to change the year. Then we have OB history. Gravida is the number of times that mom has been pregnant, no matter what the outcome was. Okay, no matter. So if she had a miscarriage at 6 weeks, that's gravida 1, that's G1. If she had a miscarriage, 2 miscarriages, that is G2. And then don't forget to count that if she's, here today for her prenatal visit and she's had 2 miscarriages in the past, then that would be a G3 because she's pregnant this 3rd time. So the number of times a mom has been pregnant. Parity is a more specific history of what gravida is, because all we know in gravida is the number of times she's been pregnant. But now in parity, we're going to talk about that pregnancy or those pregnancies. Okay, and parity is the number of deliveries. So she could have had this, first and only pregnancy until now, and that pregnancy could have been twins, but that multiple birth counts as 1. So that is the one parity, that is the one delivery. So if that's all she's had, let's say, we could be gravida 2 because she's been pregnant twice, the first one with the twins and now, so that's gravida 2. And parity is a number of deliveries. Well, right now, because she hasn't delivered yet, right now she can be gravida 2, parity 1, okay, for the multiple birth, because that counts as 1. So G2, P1. That's for that example. Now, when you see it in the charts, a lot of times you're going to see a G over P. So you're going to see, let's say for that patient, you're going to see 2 over 1, okay? And then, or you're going to see numbers, okay, next to it. 4 numbers, a G and then an O, a G over, let's say 4 numbers. What they're doing is they're trying to find out the parity. So there is an acronym, and that's FP&L or TP&L, okay? And that's all talking about the deliveries, okay? So FP&L, so full terms, preemies, abortions, and living, or T for full term, preemies, abortions, and living, okay? The full term, the number that we're going to put there is the infants that are born at 37 weeks and after, okay? Right at the 37 weeks and after, okay? So 38, 39, okay, at the 37 weeks or after. Preemies are infants that are born between 20 and 36 weeks. Okay, so anything less than 37 weeks. Abortions, pregnancy that ends in spontaneous or therapeutic less than 20. So if you have a mom that had a miscarriage at, let's say, 18 weeks, that's going to go under abortion. It will not be considered a preemie, okay, until it's after 20 weeks. Okay, so yes, her baby didn't make it, and the baby was only 22 weeks. Okay, but that will be considered a preemie. But if she had a miscarriage at, let's say, 19 weeks, and yes, the baby didn't make it, she had a miscarriage at 19 weeks, then that will obviously be considered under abortion. Okay, so any pregnancy that ends in spontaneous or therapeutic, okay, spontaneously, or she went in and went and had an abortion, and it's less than 20 weeks, it goes under A. And then L is the number of children that are currently alive. Okay. Now, after in the history, we'll talk a little bit about that again. As more lectures to come, we will go through this also when you're in lab for the skills day as well. Is after that, when we have the OB history, we call it we explain a little bit further what's happening, and usually we'll do the FP&L, we'll do all those numbers, and then let's say if mom had those twins, so she had, were they full term infants born at 37 weeks and after, and were they full term? No. So you're going to get, full term 0, and then a P, infants born between 20 and 36 weeks. Well, that particular mom, let's say that we're working up the G over P, and she had twins, we're going to say, yes, I delivered them at 34 weeks. Okay, so she delivered them at 34 weeks. So the F is going to be 0. The P will be 1, okay, because it was one delivery at 34 weeks. The A will be 0 because she didn't have any spontaneous abortions. And let's say the living is 1. Well, something happened to the other twin. So a further explanation under these numbers are going to be what happened. Okay, and they could say, one baby was born and was well, alive and well, and the second baby was, let's say, died in the neonatal ICU, 10 days after delivery. Okay, that will be, you'll put that as a better explanation under that. Okay, medical history. In past medical history, that's also very important. Okay, surgeries are important, chromosomal abnormalities are important. Part of the prenatal screening that mom fills out when she comes for prenatals at the healthcare provider's office, at the clinic. It's provided by, they're all the same. It's either ACOG or A1, okay, American College of OBGYN, or A1, which is all of the practice for OBGYN, okay, and that's the American Women's, it's neonatal nursing and OB nursing, okay, as well. So that's A1 and ACOG. You have the nursing, which A1, which also covers the advanced practice, and you have the ACOG for the College of Medicine. So you have both practices that are actually guiding, the care and putting the rules and the policies and the procedures for OBGYN. And their prenatal records are are going to be, they have to hold everything in there, has to be the same. Now, different computer systems can have different ways of putting the information in the computer systems, in the different healthcare providers' office, the clinics. Everybody has a different system, but the information is all pretty much in there. Okay, so all this information about gestational age and OB history and medical history and past medical history, all of that is going to be in there. Okay, and part of that is also that chromosomal abnormalities. Okay, anything in past medical history that has anything with genetics. Okay, that's also going to be in there. There are some questions that are asked, and we will also show you a prenatal record as well when you come to the skills lab. Okay, but you can look up ACOG, ACOG, American College of OBGYN, ACOG, or A1, AWHONN. Okay, women's health, OB, neonatal nursing. Okay, the A1 or the ACOG, and you can look up prenatal record and you could see it. Okay, those have samples on there and all this information that I'm telling you. GYN history is important under medical history and past medical history, and that's last PAP, was it abnormal or not, prior infections, STDs, okay, sexually transmitted diseases are important, previous history, previous history of or previous surgeries, menarche, okay, the regular duration, okay, when they started their periods, dysmenorrhea, let's say contraception is important, because let's say that now this uterus and, you've had, let's say 8 babies, and with every risk of deliveries, the uterus has a harder time contracting and coming back to pre-pregnancy state, okay, and that is a process called involution. So we worry about that, because that could cause bleeding when mom is delivering, okay, and that would be a postpartum bleeding if mom has delivered 10 times and now the lining of the uterus becomes thinner and thinner. So that's why when we're talking about GYN history and why it's so important, the past medical history, and especially GYN, when it comes to contraception, is because we want to let her know that, with the more deliveries of the more babies, your uterus is prone to bleed, okay, to have a postpartum hemorrhage. So we just, are concerned if that's a mom that has had, let's say, 10 deliveries. Okay, so again, to repeat the GYN history, going on the medical history and the past medical history here with the surgeries and the chromosomal abnormalities, we're talking about last PAP, which is abnormal or normal. We're talking about prior infections or STDs, previous surgery, menarche, so are they regular, okay, periods, so are we regular, duration, dysmenorrhea, okay, contraception, so we were talking about the contraception, that's so important. And sexual history is obviously important as well too. Prenatal visits, okay, this is exactly what is going to happen when mom goes to the OBGYN and will have her prenatal visit the day of. Okay, we always take a blood pressure. We'll always take a weight. Okay, we always do a fundal height. Okay, so this is fundal height with on centimeters. Okay, the tape on measuring tape on centimeters. Okay, the centimeters on the fundal height equals the weeks of gestation. Okay, so just above the symphysis pubis is about 10 to 12 weeks. At the umbilicus, it's about 20 weeks. Okay, at the umbilicus, it's about 20 weeks. So fundal height during the second, and that's another picture on fundal height, so that you see as fundal height grows, okay, 12 weeks, okay, 20 weeks, okay, as it grows, okay. So back again to the prenatal visit slide with fundal height, okay, centimeters equals, I'm sorry, I insist on going forward, centimeters equals the weeks of the number of weeks gestation. Okay, so during the second and third trimester, the height of the fundus in centimeters is going to be approximately the same as the number of weeks of gestation. So during that second and third trimester, the height of the fundus in the centimeters is approximately the same as the number of weeks of gestation. And it's always plus or minus 2 weeks. So this is a great marker when your patients come in, they come into the hospital, they come into the healthcare provider's office, and they tell you, how many weeks are you supposed to be? And of course, you've done the Nagel's rule, so you know that the EDC or the expected date of confinement or expected date of delivery, okay, the EDC or the EDD is, let's say, today, by those dates, she is, let's say, 28 weeks. Well, then you know that when you measure, it's supposed to be 28 weeks plus or minus 2 weeks. Okay, that's how we know that the baby is growing inside the uterus with the dates, okay, that mama is, and by size, okay, how they're supposed to be growing. So this is a very good, fundal height is a very good measurement to know how that baby is in utero, okay? So fundal height plus or minus 2 weeks. Then we do a fetal heart tones, okay? We movement, and insist on going forward. Fetal heart tones, movement and heart rate. Then we do a urine dipstick for glucose and protein, and then edema. We always check for edema. Okay, and then follow-up prenatal visits will be every 4 weeks until 28 weeks, every 2 weeks until 36, and then every week until that mother delivers. Then we will do some lab screening. And initial labs, a lot of these you know, so we can go through them. Okay, initial labs, so hemoglobin and hematocrit, white blood cells, a blood type and cross for an RH. We're going to do rubella. One thing I wanted to mention with the RH, find out if mom is RH negative or not, is that she will receive RhoGAM at 28 weeks and after delivery if she is RH negative. Okay, she will receive, the mom, okay, patient will receive RhoGAM at 28 weeks pregnant and after delivery. She has up to 72 hours after she delivers to receive the RhoGAM. If not, then miscarriage can happen. Okay, so we need to make sure that miscarriage can happen, if she's not given, if she's RH negative and is not given RhoGAM at 28 weeks. Okay, so 2 shots, 28 weeks and after delivery up to 72 hours after she delivers. Okay, if the dad is RH negative, then there's no concern. Okay, we're concerned about mom. Okay, we are concerned about mom. And then some of you might say, what about if the fetus is RH negative? There is no need for RhoGAM if the fetus is RH negative. It is mom we are worried about. It is the patient, okay, we are worried about. It is our pregnant, woman that we're worried about. Pregnant patient that we're worried about. If she is RH negative, okay, then she will receive RhoGAM twice. VDRL is for syphilis. So these are her initial labs. We're going to screen. We're going to get a titer for rubella. We're going to do VRD VDRL for syphilis. We're going to do GC for gonorrhea and chlamydia. Okay, and VDRL and GC, both of these right over here, is going to be in the pap smear that we do when she initially comes in for her prenatal visit. We're going to do a cytology, so pap smear and cytology. Okay, for gonorrhea and chlamydia, of course, that is a sexually transmitted disease. Okay, so we risk gonorrhea if she does test positive. We risk neonatal sepsis, preterm birth, blindness. So it's very important that we do these screenings. And then with chlamydia, conjunctivitis, pneumonia in the newborn. So we need to make sure and get a baseline of her lab screening of her syphilis and her gonorrhea and chlamydia. Then we have antibody titer for rubella and hepatitis B. Okay. This is very important. And then we have maternal serum alpha fetoprotein. That is done between 15 and 20 weeks. Okay. The levels we get with maternal serum alpha fetoprotein can help detect NUR tube or abdominal defect. And the abdominal defect we're talking about is an omphalocele, and that's when the intestines stick out. You will learn about that in pediatrics next semester in Block 4, but we do all these testing before this newborn is born, okay? The maternal serum alpha fetoprotein that's done between 15 and 20 weeks, again, the levels can help detect neurotube or abdominal defects, chromosomal abnormalities or anomalies, Down syndrome, which is trisomy 21. If the levels are off, okay, then they're going to do an amniocentesis and an ultrasound, and we're gonna go through diagnostics in a minute here. But these labs come back, and there's and usually it's given like 1 in 50. So if you know that it's 1 in 50, that's a really low level that this baby is coming with challenges. Okay, a neural tube abdominal defect. So of course then we're going to make sure, and we're going to do some testing. Okay, so we're going to go through the list of the different testings that mamas could do before their babies are born. Okay, then we do a diabetic screen as well between 24 and 28 weeks. Okay, if the glucose is less than 140, no problem. Okay, it's negative. Okay, you have something called a 1-hour glucose tolerance test that is done, and this is the one that's done in the diabetic screen between 24 and 28 weeks. Okay, first there is a 50 gram of oral glucosa, okay, that you drink. Then the blood is drawn in an hour. If it's more, then it should be less than 140. If the results are more than 140, the glucose level is more than 140, then we're going to go ahead and do a 3-hour glucose tolerance test. Okay, so the 1-hour glucose tolerance test is this diabetic screen that we do at 24 to 28 weeks. Okay, 50 grams of glucola, which is that oral glucose. You draw the blood an hour later. If it's more than 140, then it's a positive diabetic screen. If it's less than 140, it's negative. If it is positive, then we do a 3-hour glucose tolerance test. And that's when there's a couple of things we need to do. We need to make sure if they're going for a 3-hour glucose tolerance test, there's an increase in carbohydrates diet for 3 days before the test. And mom drinks at least 100 grams. So not one bottle of 50 grams, but 2 bottles. So 100 grams of that glucose solution in the morning. Okay, they have to be fasting 8 hours prior. And then they'll draw her blood, okay? And she'll be fasting Okay, usually at about 105, that's the levels that we want. At 1 hour, she should be 190. At 2 hours, she should be 165. And at 3 hours, she should be 145. She's going to be positive for this diabetic screen, which now we're going to call positive for gestational diabetes, because it's diabetes, again, gestational. She didn't have diabetes before, now she has diabetes in pregnancy. So this is called gestational diabetes. If 2 or more are high, so fasting, 105, 1 hour is 190, 2 hours is 165, 3 hours is 145. Any of these levels, if 2 or more of these levels are higher, then she will be positive for gestational diabetes. So when there's a diabetic screen for 24 to 28 weeks, we do a 1 hour glucose tolerance test. And if not, and that one is positive, then that's the only time that we go and we do the 3 hour glucose tolerance test, because we want to see if mom at this point is positive for gestational diabetes or not. Okay, then we can also test her for HIV and do some genetic screening. If remember in that prenatal screen, there's questions on genetic screening. So if those questions she answered positively, then we're going to do more genetic screening. And for example, Hispanics, African Americans, those we test for sickle cell. We do genetic screening and we test for sickle cell. From Jewish descent, we do Tay-Sachs disease. If they're Mediterranean ancestry, we do thalassemia. So depending on if those questions come back positive, then we'll do some genetic screening. Okay. Well, we're going to talk. We're almost at the end. We're going to talk about torch infections. Okay. And torch infections, that is the acronym. Okay. The acronym for torch is T for toxoplasmosis, O for other infections. You see them there: HIV, hepatitis, GBS, syphilis, and varicella. R for rubella, C for cytomegalovirus, and H for herpes. Okay. Now, the definition of torch infections: this is a group of organisms that cross the placenta and affect the development of this fetus. Okay. It's a group of organisms that cross the placenta and affect the development of this fetus. Okay. Toxoplasmosis is between toxoplasmosis, GBS, and herpes are the ones that you're pretty much going to see. Hopefully, we've given enough education with toxoplasmosis that patients won't have it. Okay, usually 1 in 900, develop toxoplasmosis. So remember, this is a group of organisms. All these are organisms. They cross the placenta and affect the development of the baby. And we're going to talk about toxoplasmosis. And toxoplasmosis is a protozoal infection that's caused by, 1, eating improperly cooked meat. So make sure everything is cooked that mama puts in her mouth while she's pregnant. And 2, contact with cat feces or cat litter with toxoplasmosis. Okay? In contact with cat feces or cat litter. So maybe this is the time if mama loves her 4-legged cat, little 4-legged baby, and this is the time that if she is going to take care of this, maybe she should have this cat in a friend's house, family's house, or somebody else care for the cat and change the cat litter and deal with the feces. Because I wouldn't even recommend wearing gloves. I just wouldn't recommend going near that cat litter, at all while she's pregnant. This is really important. If she does become positive for toxoplasmosis, this causes fetal brain damage and a big incidence of abortion or miscarriage in that first trimester. So let's have her stay away from the cat litter and the cat feces, please. O, for other infections, here's where we have HIV, here's where we have hepatitis, here's where we have GBS. Now, GBS is famous. You'll hear about GBS when I'm doing the labor and delivery lecture. Okay, it's group B streptococcus. It causes preterm labor. It causes that rupture of membranes, that premature rupture of membranes, and it also causes UTIs, urinary tract infection, with those when you're positive for GBS. So what does the CDC recommend on GBS? Well, we have to test mom for GBS infections, right? We need to make sure that if she's going to deliver, before she delivers, we will take care of her with antibiotics because we don't want to pass it on to the baby. Okay, so she is tested usually within 5 weeks of delivery. So usually between 35 and 37 weeks, we're going to swab vaginal and rectal area, okay, for GBS. Okay, and that is what CDC recommends, okay, for GBS, group B streptococcus. Okay, we're going to test it within 5 weeks of delivery. So usually one of those at the end of those prenatal visits, one of those prenatal visits between 35 and 37 weeks, we're going to swab vaginal and rectal area. Okay, and if she is positive for the GBS, we're going to give her a prescription. So when she is in labor and she comes to the labor and delivery, that they know that she is positive for GBS and we're going to treat her. Okay? And the antibacterial agents that we will do is we will give her penicillin G. Usually what's preferred is penicillin G, 5 million units IV piggyback, and then we give her 2.5 million units every 4 hours until delivery. That's the preferred. Or we can give her, depends, different hospitals. We can give her ampicillin, 2 grams IV piggyback as a loading dose. And then we can give her 1 gram IV piggyback every 4 hours until delivery. Now, if she is allergic to penicillin and has a low risk for anaphylaxis, then we can give her Ancef. And again, we'll give her 2 grams IV piggyback as a loading dose, and then 1 gram IV piggyback every 8 hours until delivery. Okay. And then, for example, if she is allergic to penicillin and she has a high risk of anaphylaxis, and sometimes you will see that they'll give her clindamycin, and they'll start with 900 milligrams IV piggyback every 8 hours until delivery. Now, I just gave you labor and delivery admission orders, and this is those set admission orders that you will find in the labor and delivery room. You will find these, and it's as simple as labor and delivery admission orders. Okay, medications. It's under meds, is under the meds for L&D admission orders, and you will find their GBS. Okay, as standard orders, and if they will tell you just like I told you. Okay, antibacterial agents. If you're positive, you can give one of the following. You can give penicillin, is a preferred, ampicillin. And if they're allergic and they have a low risk, is usually Ancef. If they have a high risk, it's usually clindamycin, and even some hospitals might give her clindamycin or vancomycin. Okay. If mom, and that's of course, you've got the prescription, here it is, I'm GBS positive. If we come in, and again, I keep saying prenatal visits are amazing if mom goes for prenatal care, but we do see patients that don't go for prenatal care or start prenatal care so late, or maybe go once and they don't go again. If that's the case and we are under GBS unknown, we are going to treat mom because we don't know, and it is so important. So if GBS is positive, this is what we'll do for antibiotics. If we don't have a GBS, we don't know, we don't have that order, we don't have any results for GBS, then we're going to treat her and it will be GBS unknown. Okay. Syphilis. and varicella. Okay, so we're going to treat for both of those. We're going to do testing that we said we were going to do. Remember, we're going to do the titer for rubella titer, and we're testing also for, remember the swab that we did when we did the labs, when the mom went for prenatals. Okay, so that's her rubella. CNV as well. It's a member. CMV is a member of the herpesvirus family. There's only about 1% of babies that are born with the infection. They're usually, mama has had positive sexually transmitted diseases, STDs, and she hasn't been treated. Babies will get cold sores, will have the bacteria. If they are born with CMV positive, they usually have mentally. I never use a word mental retardation. We don't use them anymore, but you will see that in your book, in your readings. MR is mentioned, disability, okay, and also auditory impairments with a positive of CMV. And then herpes, okay, herpes simplex. That could be contracted during vaginal delivery process. These are genital lesions that can be present at the time of birth. If herpes is present at the time of birth, then we will do a C-section on mom. Okay. If the infection invades, okay, if the infection comes to town with mom, okay, and shows up in the second or third trimester, then there is a high incidence of premature birth, intrauterine growth restriction. We used to say that's another example of not using the retardation. We used to call IUGR intrauterine growth retardation, and that has stopped to intrauterine growth restriction. Okay, it means that the baby's not growing the way it's supposed to in utero. There is a restriction on the growth. Neurologic disease, okay, and of course that continued infection of the newborn at birth. So prenatal care again becomes so important one more time, because we will look at mom, we will get a baseline of mom, we will ask her all these questions, we will look, and if there are genital lesions present, then of course we're going to treat her. We don't know what we don't know. So if the infection does invade her, does show up at second or third trimester, then there's a higher incidence that all of this can happen. But that's why prenatal, it's so important, because we'll ask the question and we can actually see her. Okay. Now, if the infection does take place in the first trimester, and all of a sudden, in the first trimester it happens as well, hopefully we can treat her. Okay. Because if she doesn't know, then of course it could be severe congenital anomalies. Spontaneous abortion can happen. Okay, and if in the first trimester she's got, she shows up with herpes, or she contracts herpes in the first trimester and doesn't do anything about it, then of course, that can provoke a miscarriage. If it's in the second or in the third, then of course you have that premature birth, neurological disease that can happen, and then that infection that's going to go to the baby when the baby's born. But hopefully she'll go for prenatal care. We'll do the history. She'll tell us she has a history of, and then we can give her antibiotics, okay? And anytime there's a history of, we can give the drug given prophylactically, okay, at 36 weeks, okay, to prevent a lesion at the time of birth. Okay, so if that's the case, we can give the drug prophylactically. And what we're going to give her are her antiviral treatment. We're going to give her acyclovir, and the next one is valacyclovir. So acyclovir and valacyclovir.